Okay. My name is Galvin. Nice to meet you all. Thank you for making the time. I'm a PGY6 GI fellow. I'll talk about different hepatitis. Um, we'll start with Hep B and then go on to the other ones. I have to be in clinic at around 1, so it's not possible to cover everything. So maybe we'll do it in 2 classes instead of rushing through. So how many of us here are intimidated by hepatitis B serologies and how you interpret them? Okay. First years? Like PGY4s? Med student. Okay, cool. Um, the rest are not, so they're gonna interpret my questions and give me answers, okay? So let's start first with hepatitis B. I don't have any financial disclosures. Maybe one day I will. Okay, so let's start with the structure of hepatitis B. So very basic, what you need to remember is there is an outer layer and an inner layer. Outer layer is the envelope. It has the surface antigen. So if you see, you guys can see my pointer. Okay. So if you see the envelope, it has different sizes of the HBsAg, which is hepatitis B surface antigen, and there's large, medium, small. Then there's the inner, which is called the nucleocapsid core. It contains the DNA. It's a partially double-stranded DNA. And then in between those two is the HBe antigen. And then within the nucleocapsid core is the core antigen. So 3 different things: surface antigen, E antigen, and the core antigen. And then the DNA, it's a double-stranded DNA hepatitis. And then we'll know the clinical relevance of these in the next few slides. It has 10 different genotypes in case anyone asks. And genotype C is the most dangerous one. In the US, you mostly see genotype A. The relevance of genotypes is not, it's not as useful anymore because the medications we have are pan-genotypic, but sometimes you still order it just to find out how much are they predisposed to getting cancer or scarring, like how far is their risk. So sometimes you order it, or when you're doing interferon based therapy, because interferons help with certain genotypes, not with all. But that's I don't think you guys need to know that as much. So let's talk about the serologies, and hopefully we change that today and nobody's intimidated after today. So surface antigen on the surface, what does it indicate? It indicates active infection, okay? So negative means no active infection, and then positive means active, and then depending on the duration of how long it's been positive, if it's more than 6 months, it's chronic; less than 6 months, it's acute infection. So negative could be that they've never been exposed or they cleared it, but it's very, very unlikely that somebody gets hepatitis and they're able to clear the surface antigen. And then also important, so anything in red is something that we should remember. That's so post-vaccination, they can have a positive surface antigen for about 2 weeks. So surface antibody is the antibody towards the surface antigen. What does it indicate? It indicates immunity. Immunity could be from vaccination, or immunity could be from previous exposure. So those are the 2 things that you need to remember. If somebody's positive for surface antibody, they're already immune. You don't need to vaccinate them. You don't need to worry about their risk for hepatitis B unless they're immunocompromised or they're on certain medications. We'll talk about them. Okay, E antigen, you see the structure on the right again. Between the envelope and the core is the E antigen. What does it indicate? It indicates high viral replication and high chance of infectivity. It can be seen in acute infection or chronic infection. Now, if the E antigen is negative, that means they could have hepatitis, but they're better controlled. It's basically a surrogate for hepatitis B DNA level and the ALT, the liver enzyme. So if it's negative, that means they might have good control of their hepatitis. E antibody is the antibody towards the E antigen, And if E antigen is negative, you expect the E antibody to be positive, and that means the viral replication is suppressed and they're at low chance of infectivity. Lastly, the core antigen, it lies within the nucleocapsid core. It's not detected, we don't test for it, okay? It's not in the blood, so it's not relevant. What's relevant is the core antibody, and this marks infection history. So IgM core antibody positive means acute infection, and then IgG is going to persist for life. That means history of chronic infection. So this gives you a history of infection. Surface antigen means it's active infection. Surface antibody means that they're immune to it. So if the core antibody is positive, but the surface antibody is not positive, that means they've been exposed, but they're not immune. So those people you have to vaccinate. All right. So this is pretty high yield. You'll get this on your board exams, and this is a summary of it. And as you do more and more practice questions, it'll start to make more sense. I was also intimidated by it until actually my final year of residency, but now I've seen multiple patients and I've read about it, so it becomes easier. It's not that complicated, and we'll do this practice exercise after this slide to make it easier. So what are the CDC recommendations? So vaccination for all. Usually you get vaccination in the first year as a child, but actually at birth. But if you're not vaccinated, you can still be vaccinated later on. That's one thing. The other thing to remember is your primary care clinics, the patients who've never been tested for hepatitis, make sure you check for hepatitis B and hepatitis C. We'll talk about hepatitis C if we can get to it today, otherwise another day. But make sure you do one-time screening, okay? All my patients in the liver clinic that come, I just order it. It's you might not, you most likely it's going to be negative, but it's the one person that you catch positive and you can treat them, it makes a huge difference. Otherwise, they'll come in asymptomatic, but later on with cirrhosis, and you want to avoid that if you can. And then, of course, risk-based screening, the patients at high risk, apart from pregnancy, if they have those behaviors that are mentioned, you want to test them as well. So question, so what screening tests will you order? You don't order everything. What are the specific screening tests? And it's okay to be wrong, just guess. Okay, that's one. There's two more. C antibody? Did I hear C antibody? Yes. What else? So surface antigen, surface antibody, and core antibody. Those are the only three tests you need initially. In our, like, in the hospital, we have an acute hepatitis panel that only has the surface antigen. It doesn't have the core antibody. It doesn't have the surface antibody. So ideally, we should be ordering all those three tests. Okay, so let's say you order those three tests, and this is what it comes out as. What does this mean? Everything's negative. What does this mean? Okay, no prior vaccination, no exposure, right? They don't have hepatitis. What would you recommend for them? Vaccine, yes. So we're gonna, like, we broke it down, that's how we're gonna do this exercise. So negative surface antigen means no active infection. Negative surface antibody means not immune. Negative core antibody means they've never been exposed to it. So in those patients, you advise vaccination. Okay, next scenario is negative surface antigen, which means no active infection. Positive surface antibody, which means they're immune. That could be from vaccination, that could be from exposure. Positive core antibody, previous exposure, right? So no active infection, they're immune from prior exposure. Okay, those are the three tests that you need. That's it. Okay, next scenario, only positive surface antibody. What does that mean? Recent or? So surface antibody, if it's positive, that means they're immune, whether it's from previous vaccination or from previous infection. And how you would differentiate that is negative core. So vaccination won't cause a positive core antibody. So this person is immune, and it's like this one is from vaccination. The previous person, this one was from prior infection. Okay, so no active infection, immune, and no prior exposure. Uh, and then this, like my program director likes to ask this question. Let's say so there's the anti-HBs or hepatitis B surface antibody. There's a qualitative test and a quantitative test. And let's say you order the quantitative test, and it comes below a certain number, then they're considered not immune. Do you guys know what number that is? Huh? Yeah, whoever answered. Yeah, 10 is the number. So if you order quantitative and it's less than 10, they're not immune. You should vaccinate. All right. So now we have a positive surface antigen, negative surface antibody, positive core antibody. What does this mean? So just try to break it down. Positive surface antigen, what does it mean? Active infection. Negative surface antibody, that means they're not immune. Positive core antibody, exposure. So this is likely infection, and based on what core antibody is positive, if it's IgM or IgG, it would be acute or chronic infection. Okay. And these are the patients where you do more testing, and we'll talk about, like somebody said, e antigen. All of those things you do in patients who are positive for Hep B, which is either active, either acute or chronic. That's where you order e antigen, e antibody, HBV DNA level, liver enzymes, and then core IgG or IgM to determine if they're acute or chronic. And then based on that, and I'll cover that, based on that, you decide what phase they're in and if you treat it or not treat it. Okay. Next scenario. So positive surface antigen, active infection, negative surface antibody, not immune, positive IgM core antibody. So what kind of active infection is it? Acute. So acute IgM core. So acute hepatitis. And then positive e antigen. What did e antigen mean? Infectivity. So high infectivity. So acute infection with high infectivity. Okay. All right. Positive surface antigen for more than 6 months. That means active infection, acute or chronic? Chronic. Okay. Negative surface antibody, positive total core, negative IgM core. So chronic Hep B, and then positive or negative e antigen means high or low infectivity. Okay. All right. Next scenario, and please feel free to stop me if something doesn't make sense. This is your time, okay? Don't hesitate. Next one, negative surface antigen, negative surface antibody, positive IgM core antibody. So no active infection, not immune, exposed. What does that mean? Yes. So yes, correct. So that's why you do those three tests initially, and those will give you whatever you need to know. But you see the picture on the right, and there's a time between the surface antigen becoming negative and the surface antibody appearing in the blood, and that window is called the window period. And the only thing that's positive at that time is the anti-HBC, hepatitis B core antibody. Okay. All right, last scenario. This is a little complex. So everything's negative except IgG core antibody. So it's not the window period. So there's three possibilities here, okay? And we'll talk about them, but essentially, one is that this person had surface antibody, but got immunocompromised, or he or she has it, but not as much as to cause a positive blood test for surface antibody. Okay. Two is it's a false positive test and you repeat the testing. Okay. And third is occult infection. I don't think you guys need to know. It's more for GI ID. And the best next step in these cases is to do a DNA level. And based on if the DNA level is high or low, you'll know what out of those three is it. So these are the four possibilities. The fourth one is the window period we talked about. That's more for IgM core antibody, not for IgG. So number one, number two, and number four are the three possibilities. If it's isolated, it's called the isolated core antibody positive. Okay, and you do a serum HBV DNA level. All right. So in terms of acute and chronic, there's acute and chronic Hep B. Mostly they're asymptomatic and they usually present when they already have some scarring or fibrosis. That's why we try to catch it before it reaches that stage, because they're infectious and then they can even spread it within the family through different mechanisms. We'll talk about that. INR is used for prognosis. We all know that. And then IgM, anti-HBC, is going to confirm acute infection. Only 1/3 of adults develop symptoms, so 2/3 don't even have symptoms. And then chronic Hep B, you might see it with some scarring, so you might see some symptoms of cirrhosis, whether it's compensated or decompensated cirrhosis. And then how you tell if it's chronic is IgG, anti-HBC, plus HBsAg positive for more than 6 months. Okay. All right. So you have a patient with Hep B. Based on those scenarios, you found that this patient has acute or chronic Hep B. Let's say you have this chronic Hep B patient. So in the clinic, and you guys probably refer, but if you want to do some workup or even here, these are the tests that you order. So the next steps, like we talked about, HBe antigen, E antibody, HBV DNA level, liver enzymes. Plus, you want to do imaging of the liver to see if they have scarring or cirrhosis or fibrosis, because it has implications on treatment. There are certain stages you don't treat unless they have fibrosis. Okay, and then you want to make sure you also check the other hepatitis C, hepatitis A. If they're not immune to hepatitis A, you vaccinate them, because if they have hepatitis B, it doesn't excuse them from hepatitis A. And if they get hepatitis A on top, everything's going to get accelerated and their liver's going to get scarred faster. So when do you test for hepatitis D? We don't do it as much here because it's not as prevalent, but you test for hepatitis D if their surface antigen is positive. And I have hepatitis D in here if we can get to it, but essentially hepatitis D needs hepatitis B surface antigen to infect a person. So if the surface antigen is absent or they're immune, you don't even have to test for hepatitis D. Also, the other thing to remember, usually cirrhosis is what leads to HCC, hepatocellular carcinoma, but HBV is one of those few conditions that patients can have HCC without cirrhosis. So you still, even if they have just fibrosis, not F4 fibrosis is cirrhosis. So if they have F2, F3 fibrosis with chronic Hep B, you still do your surveillance with ultrasound and alpha fetoprotein every 6 months. Okay. All right. So this is where I was talking of. So you do, you found a chronic Hep B patient, you order all those tests, ALT, DNA, E antigen, and based on that, per our AASLD guidelines from last year, you divide them into these phases. And the first three are the ones that are relevant for you guys. You guys don't need to know the other phases, but you don't treat inactive CHB. Okay, you guys will get questions on it where they'll give you a scenario and ask you if you're going to treat or not. So E antigen negative, ALT normal, and DNA less than 2000, you're not going to treat. Now, on the other hand, you treat immune active CHB. Active, basically, I remember it with ALT level. If ALT is higher than 2 times the upper limit of normal, I'm going to treat it. If it's lower, don't focus on the gray zone, but if it's lower, then it's likely inactive. Now, there's immune tolerant, which is somewhere in between. The ALT is still normal, so you're not going to treat it, but they have high DNA. So don't be worried if they have high DNA. Now, the latest guidelines did say that you treat certain populations in this scenario, in the first scenario, and that's if you do scan and they have their age over 40 with F2 or F3 fibrosis. That again, I don't think you guys need to know. All you guys should remember is immune active versus inactive. In terms of treatment options, so historically we used to use interferon. It had a finite duration of therapy, which is 48 weeks. It's a subcute weekly injection. It causes local side effects as well as drug interactions, and it wasn't pangenotypic. And like not all patients would respond to it, so it's fallen out of favor. What we have now is these options, and realistically, it depends on the insurance and what they cover, but we use all of these. What you guys should remember is between TDF, the second one, and TAF. TAF is slightly better. It has two advantages. One, it does not, you can use it in patients with kidney dysfunction. You can't use TDF in those. And then two, TDF can cause decreasing bone density. TAF doesn't. And they'll give you this scenario too. And they might mention one of those two, and you have to pick which drug you'll use. Just remember TAF is better than TDF, but it's also going to be more expensive. Besides that, also any patient with Hep B cirrhosis, you're always going to treat. Compensated cirrhosis, you can treat it just like anything else. Decompensated, there's more nuances to how you treat it. You want to have transplant team on board and all that, but again, I don't think you guys need to know. Okay, let's do this question. So we have a young female with lymphoma. She's starting or planning to start chemotherapy with rituximab. So let's try to determine the phase. So ALT is normal, surface antigen negative, IgG anti-HBC positive. That means previous exposure with no active infection, and also she's immune, and the HBV DNA is undetectable. So what phase is this? We can go back to that. So what phase would this be out of the top three? So it's going to be inactive. Yeah, it's going to be inactive. And so if it's inactive Hep B and you're starting rituximab, which is a B cell depleting agent, what would be your best next step? Would you want to treat the Hep B? Would you want to monitor it? What would you like to do? Monitor? Yes, so I also used to think that, but the risk is with a B cell depleting agent, the patients can go from inactive to active phase. Because remember, it's a DNA virus. You're not cured from Hep B. It's always going to be in your cells. So patients on a B cell depleting agent can get reactivation. So you treat it. If it was another medication, not a B cell depleting agent, then yes, then B would be correct, that you just monitor. Okay. This is also a question that I don't remember if I got it on GI or on IM boards, but just remember this. Rituximab, treat. All right. So in terms of, so you have a chronic Hep B patient coming in decompensated with ascites or GI bleeding or encephalopathy, hospitalized. So what are the things that they can have? Because usually chronic Hep B is asymptomatic. So they can have reactivation, meaning acute on chronic Hep B. And this is where it gets a little complicated because IgM is going to be positive. And IgM we thought was just acute infection. So this is acute on chronic infection. And then immunosuppression we talked about, like rituximab. And then interferons, we don't use it anymore. So we don't have to worry about that. And then that's why we do all the other hepatitis checks, because they can have superimposed Hep C, they can have Hep A or Hep D if their surface antigen is positive, or other causes of liver disease like alcohol use, medications. There's a ton of them, but these are the different scenarios. And with that, we'll transition to Hep D. Um, so I'll try to get through Hep D and Hep C. Hep A and E, we can do it next time because I want to do some questions instead. Okay, so Hep D, RNA virus. Everything else except Hep B are all RNA viruses, okay? Not prevalent here. There's co-infection versus superinfection. You guys should know the difference. And then exposures, there's different ways that you can be exposed. And now, if you're immune to Hep B and you won't have surface antigen positive, and Hep D needs the surface antigen to infect somebody. So if you're immune to Hep B, then you can't get Hep D. The only way you can get Hep D is if you have Hep B surface antigen in the blood. In terms of diagnosis, we'll talk about it, but besides Hep B, others, you're just testing one antibody, so it gets simpler. It's not as complex as Hep B interpretation. And then prevention is just vaccination. Vaccinate for Hep B. That's what you need to know. All right. So co-infection versus superinfection. I have a picture in the next slide. But what co-infection means is that you're getting infected with both at the same time. Superinfection means you already have chronic Hep B and then you got Hep D on top of it. Which one is worse? Just take a guess. Superinfection is worse because they already have probably have liver damage, and now there's a second hit. Co-infection, there's a chance that it actually self-resolves, and the risk of acute liver failure is lower versus superinfection. What the line at the bottom says is if you have two of them, then obviously the disease is going to progress faster than if you just have one of them. So in terms of differentiation between co-infection and superinfection, what do you think, what test would help differentiate? It's somewhere here, but what test, based on the serologies that we talked about that probably don't make as much sense right now, but what test will help differentiate if it's a superinfection or a co-infection? Yes, good. Good. Yeah, core antibody. So anti-HBC, if they're positive, and you can see it in the first diagram, the one in green, the dotted green, it's not there in the second one. So that's how you differentiate co and super infection. You don't need to know that. What I put this in because I wanted to show you. If you see the Hep D RNA and the genome in let me point it. Right in the center, and the surface antigen is what completes the structure and what's required for it to infect the cell. So without the surface antigen, Hep D can infect. And then I don't think you need to know like the different steps and where we can treat it if we need to treat it. Okay, Hep C. All right. So another RNA virus, genotype 3 was the most infectious one for Hep C. So genotype C for Hep B and genotype 3 for Hep C. There's 8 genotypes. Again, most people asymptomatic can spontaneously clear, and then chronic infection will lead to likely fibrosis and cirrhosis. So extrahepatic manifestations of Hep B and Hep C, I have a slide on it. They're very high yield for you guys. You'll get questions on it all the time. And then people who are likely to spontaneously clear, or if they don't have any other infections, also if they're symptomatic. Usually we tend to think if somebody's sick with symptoms, they're likely going to stay sick, but they're actually interestingly likely to clear it. And then fibrosis, meaning scarring, genotype 3 is the worst one, and then older age or other hepatitis. All right, so what does this picture show? Can anybody describe the rash in relation to Hep C? What kind of rash is it? Just one. It's okay to be wrong. I can't hear, like, you have to be louder. Okay. What is the rash though? So it's a purpuric rash. Purpuric rash from, that's good. You guessed it right, from mixed cryoglobulinemia. This is from my first aid, but basically Hep B and Hep C, you guys should remember the extraintestinal manifestations. My PD likes to ask which glomerulonephritis is with which Hep, and I always forget. But membranous Hep B, membranoproliferative, longer name comes after, so Hep C. That's how I try to remember it. And leukocytoclastic vasculitis or the cryoglobulinemia, you can get a lichen planus question too, and they'll ask you what you should test, and it's Hep C. So remember this. Always go back to your first aids before your exam, because you're gonna definitely get a question on this. Okay. In terms of Hep C testing, very similar to Hep B. It's pretty simple. You want to screen everybody at least once in their lifetime, and then if they have risk factors as teenagers, you can also screen them. And then you're not done if it's negative ×1. If they still have risk factors, they can always catch it. So for them, you do periodic screening. And the picture is showing that the patients in their 20s, there's a higher rate of Hep C, so we need to be more vigilant with our screenings and catch it, because Hep C is curable. Hep B is treatable, Hep C is curable. It's only an 8-week to a 12-week treatment. So if we catch it, we can treat them before they get cirrhosis. Okay, so things to remember for Hep C, the different ways that it's a blood-borne virus, so different ways that you can get it. And it's not just IV drug use. I know we tend to ask about IV drugs, but it's also intranasal drugs. So don't forget to ask about that. If they've been transfused blood, and they'll give you the scenario and they'll tell you that this person got blood or whatever in 1985. So that's where you think, oh, maybe it's a Hep C question. And then pregnant females also you want to test. All right, so let's interpret Hep C. So Hep C is simpler. All the other Heps are a lot simpler, only antibody and RNA. So how do you interpret this? The first one, second one, third one? Okay, the first one is active infection. What about the second one? Prior infection, resolved infection, or a false positive. Forget about the false positive, but yes, prior infection, they're immune to it. You don't have to worry about it. What about the last one? Active infection, they have not formed antibodies yet, or a false positive, or immunocompromised, that they can't form antibodies. Okay? All right. So we discussed this. And then just to remember, HCV RNA, let's say this happens when you get a needle stick and you want to get tested immediately. Nothing's going to come back positive immediately, because even RNA takes time to form. So you want to wait 2 weeks, okay? And antibodies take a few months to form. Okay, all right. These are the different medications that you use for Hep C. I don't think you guys need to know this in detail, but um, it helps to get an idea of it. What it's showing is it's an RNA virus, okay? So it's gonna go inside, and then there's gonna be translation and reverse transcription. And the medications work on those things. So the protease inhibitor, protease cleaves protein. So those work on the translation part. Okay, they prevent protein maturation, and they all end with PREVIR. Okay. Then there's replication inhibitors, and one of them inhibits the replication complex as shown here, and the other inhibits the enzyme that's needed for replication. So the ones that inhibit the enzyme are called, they end with BUVIR, and then the ones that inhibit the replication complex, they end with ASVIR. So those are the three different broad classifications for the medications. I don't think you guys need to know beyond that. And then know that usually the duration of like simple Hep C that's not been previously treated is the duration is 8 weeks treatment with one of the medications. That medication is 3 tabs daily, so it has a higher pill burden. And then that's called Mavorite. Okay, and then Epclusa, those are the ones that we most commonly use. Epclusa is a 12-week treatment. It's a daily medication. And then realistically, it also depends on if what do you call it, what insurance covers. Besides that, I don't think you guys really need to know, but in cirrhosis, if it's decompensated, you can't use Mavorite. Also in kidney dysfunction, you can't use Mavorite. And then this is similar to the Hep B. It's a busy picture, but similar to the Hep B, like what workup are you going to do for a patient that's positive for Hep C is check for other hepatitis and then check if they have scarring. Essentially those two things. And then based on what the results are, you treat accordingly. SVR12, does anybody know what that stands for? Viral what? Response. So sustained virological response is called SVR12. So when you treat them, you test them after 12 weeks. And if they're cured, if the RNA is negative, that's called SVR12. Now, data is showing that even if you do it at 4 weeks and they're cured, there's a high chance that they'll stay that way till 12 weeks. So it's called SVR4 and SVR12. The other thing that's important is these medications have a lot of drug interactions. We get questions on these. So make sure you check if you guys are prescribing, make sure you check for drug interactions for these. They interact with PPIs, they interact with immunosuppressants. If it's a dialysis patient on cyclosporin or tacrolimus, you guys should make sure that you're dosing it accordingly or using the appropriate medication that doesn't interact. And then let's say you have a patient in the hospital presenting with decompensated cirrhosis and they're Hep C positive, and you call GI or you call ID, and they ask you, should we treat or should we refer for transplant? What is the answer? It's one or the other. Are you going to treat it or are you going to refer for transplant? Huh? Yeah, so the key is that patients with Hep C can get a Hep C liver. So you don't want to treat it. They can be treated later. So they can at least qualify for a Hep C liver and maybe get transplanted faster, and you can always treat after, okay? I had this scenario and I actually was like, should we treat it? We should treat Hep C, it's positive, but when it comes to transplant, it has a little more than just treating it. Okay, this is Hep A questions. I'm gonna pause and then we'll do these later. You guys have till 1? Is it till 1? Okay. Then let's do the rest another time. And then I had a different question slide, but we can also do that next time whenever we can schedule. Does it make sense? A little bit? Just go back to it. It'll make more sense. I know it's a lot of information, but try to practice and challenge yourself and it'll be easier. Okay. Anything else? Any questions? Okay. All right. Thank you for your attention to this matter.